Cardiac electrophysiology is the study of electrical conduction and properties of heart muscle cells. It forms the basis for understanding, diagnosing, and treating cardiac arrhythmias and has come a long way over the past century. Significant advancements in catheter ablation techniques have made it possible to cure many arrhythmias non-pharmacologically. This field continues to evolve rapidly, with improvements in technologies taking treatment success rates higher. The study of cardiac electrophysiology began in the late 19th century when experiments by embryologist Wilhelm His Jr. demonstrated that the heart has its own intrinsic rhythm, generating pacemaker cells located in the sinoatrial node. This established the understanding that cardiac rhythm was electrical rather than mechanical in nature. In the early 20th century, Einthoven introduced the string galvanometer, which allowed non-invasive monitoring of the human electrocardiogram, ECG. This opened the ability to analyze cardiac electrical activity externally and demonstrated variations in rhythm, which helped relate clinical cardiac events to specific electrophysiological abnormalities. Introduction of microelectrodes in the 1950s allowed direct intracellular recordings from individual heart cells by scientists like Katzung and Nihon Koden. This revealed characteristics of action potentials from individual cell types like pacemaker cells, conducting pathway cells, etc., establishing foundations for modern cardiac electrophysiology. In 1964, Curtis and colleagues first recorded intracellular potentials from intact human heart, allowing correlation between cellular and clinical dysrhythmias. This confirmed that human cardiac arrhythmias had similar ionic and cellular mechanisms as those studied in animals. In 1968, Waller implanted the first permanent pacemaker that could restore normal cardiac rhythm therapeutically. However, until the 1970s, almost all arrhythmia treatment involved radical procedures like open heart surgeries. 1970s were a watershed period with development of two critical techniques, cardiac catheterization and angiography. In 1972, the first non-surgical selective catheterization of the heart chambers and vessels was performed by Forsman, revolutionizing access for diagnosis and treatment. DC high-frequency catheter ablation. In the mid-1970s, Beck and colleagues introduced localized destruction of diseased cardiac tissue safely using DC electrical current or high-frequency current delivered through a catheter electrode. This established the basic technique of catheter ablation. During next few decades, rapid advancements were made, as summarized below. 1981, first human atrial flutter ablation by Hull et al. Demonstrated curing arrhythmias non-pharmacologically. 1987, Matsu et al. Developed first radiofrequency RF catheter ablation system, replacing DC catheters with safe RF energy delivery. Success rates improved dramatically. 1988, Jackman et al. Performed first human ventricular tachycardia (VT) ablation. 1989, Heisegal identified left-sided atrial foci as common cause of paroxysmal atrial fibrillation (AF), revolutionizing understanding. 1991, Inoue et al. Performed first catheter ablation of accessory pathways, curing Wolff-Parkinson-White syndrome. 1990s, further innovations in 3D mapping, ultrasound MRI ablation guidance, irrigated tip RF catheter technology improved procedural outcomes. 1998's, introduction of bipolar electrograms and electroanatomical mapping systems helped optimize substrate ablation. 2000s, advances in intracardiac echocardiography, rotational angiography fundamentally transformed catheter ablation. Pulmonary vein isolation revolutionized AF ablation success. 2010s, introduction of contact force sensing catheters, laser balloons, robotic navigation systems established new benchmarks in safety and efficacy for complex procedures. Molecular imaging, computational modeling supported individualized approaches. Catheter ablation is now established as first-line therapy for several common arrhythmias based on large randomized clinical trial evidence establishing safety and superior efficacy compared to medications. AV nodal reentrant tachycardia, AVNRT, atrioventricular reentry tachycardia, AVRT, regular supraventricular tachycardias, SVTs, atrial flutter, idiopathic ventricular tachycardia, VT, post-myocardial infarction, ischemic VT, focal atrial tachycardia, AT. It is also an accepted treatment option for paroxysmal atrial fibrillation, PAF, persistent, long-standing AF, non-ischemic VT substrates, accessory pathways in WPW syndrome, junctional bundle branch reentrant tachycardias. Approximately 300,000–500,000 catheter ablation procedures are performed annually worldwide for a vast range of arrhythmias, demonstrating its widespread acceptance. Key aspects shaping catheter ablation today include advanced 3D mapping systems with hundreds of mapping points, pace mapping capabilities, real-time image integration from ICE, CT, MRI into electroanatomical maps to visualize catheters and ablation targets anatomically, contact force sensing technology for safer, predictable, and durable ablation lesions, customizable irrigated tip catheters with multiple temperature, power, flow sensors for high-resolution lesion creation, techniques like pulmonary vein isolation for long-standing AF, substrate ablation for scar-mediated VTs, emergence of alternative energy sources like cryoballoon, laser, high-intensity ultrasound catheter ablation, multidisciplinary heart teams including electrophysiologists, surgeons, interventionists which synergistically treat complex cases. Thus, catheter ablation has established itself as a routine first-line therapy alongside catheter-based interventions for structural heart disease to become a mainstay of cardiology practice worldwide today. Success rates exceeding 90% are routinely achieved for several arrhythmias at specialized centers of excellence. Ongoing research and innovations continue shaping the future of catheter ablation. Advancing technologies, robotic catheter navigation systems, magnetic catheters for automated contact and orientation, AI machine learning facilitated mapping, individualized ablation strategies from computational models, nanosensors, molecular imaging agents for improved soft tissue distinction and target detection, laser, high-intensity focused ultrasound catheters, low-temp thermocryo technologies, complex substrates, atrial fibrillation, tackling long-standing persistent AFib non-invasively, assessing and reversing atrial remodeling, ventricular tachycardia, novel ablation strategies for ischemic, non-ischemic, arrhythmogenic substrates resistant to standard ablation, minimally invasive techniques, catheter ablation sans catheter access, transthoracic echocardiography guided minimally invasive epicardial ablation, robotic catheter navigation from skin access points, eliminating vascular access complications, ablation for associated conditions, restoring sinus rhythm in patients with atrial fibrillation and heart failure to improve symptoms, reverse remodeling, curing arrhythmias to prevent stroke in patients with atrial cardiopathy and atrial fibrillation, catheter ablation as primary prevention for lethal ventricular arrhythmias by modifying arrhythmogenic substrates, personalized approaches, multiomics, computational modeling driven truly individualized medicine approaches tailoring ablation strategies, real-time closed-loop adaptation of ablation based on response, incorporating imaging, biomarkers of lesion formation, efficacy, adjunctive therapies, catheter ablation combined with antiarrhythmic drugs, ablative technologies like cryoballoon, nanoparticles to maximize efficacy, synergistic catheter ablation with minimally invasive epicardial interventions in complex ventricular substrates, expanding applications, treating pediatric arrhythmias, arrhythmias in inherited channelopathies, congenital heart disease, non-invasively. With limitless potential of emerging technologies and techniques on the horizon, catheter ablation offers great promise to revolutionize arrhythmia treatment further. It will likely become far less invasive, more tailored and curative, with ability to modify substrates of disease in truly minimally invasive fashion. This continues to establish electrophysiology at the forefront of modern cardiovascular medicine. Over the past few decades, cardiac electrophysiology has evolved into a sophisticated discipline, with catheter ablation establishing itself as a routine first-line treatment for most arrhythmias based upon decades of rigorous research and innovations. Its success critically relies on a deep understanding of arrhythmogenic mechanisms at cellular, tissue, and whole organ levels. Constant advancements are pushing boundaries to cure even the most complex substrates. With ongoing technological developments and integration with other specialties, catheter ablation promises to revolutionize arrhythmia care further in future by rendering truly curative and minimally invasive treatments to many patients previously left with limited options. The The future remains exciting for this fast-evolving field at the intersection of engineering and cardiovascular medicine.